Okay, welcome everyone. Thank you for coming. As I mentioned earlier, Mark Alexander is my name, sports physio and managing director of BakPhysio, and I'll talk to you about NeckRest after Ken gets on. But I'd like to introduce the legend, the master Ken Niere. In my opinion, the best musk physio. Now that Joel, I'm a Queenslander, so I'm a bit biased to Gwen up in Queensland and studied under Gwen decades ago, but she's now retired from hands-on, so to me the baton's now been passed to Ken. What do you reckon, Ken?
I'd say I'm not even the best musk physio in my family.
Okay, what, Helen? She's a Queenslander, maybe that's why. No, but anyway, putting competition aside, Ken and I ran La Trobe at the same time. I ran the sports program from 2006 to 2011, and Ken ran the musk program for the same period of time, and specialist musk physiotherapist. And I'm going to introduce Ken and his talk tonight around the latest on cervicogenic and headaches in general. So Ken will be talking for around 20 minutes, and then there'll be some Q&A, and then I'll come on and I'll talk about the science behind NeckRest. So without further ado, I'll hand over to Ken.
Thank you very much, Mark. Thanks for inviting me. Look, happy for the session tonight to be fairly casual, fairly interactive. Even though I'm sort of standing up behind the lectern, there's no PowerPoints, anything like that. So what I want to do is focus on basically musculoskeletal impairments and their relationship to different headache types. So I said it's good if it's interactive. So let's start now. Who thinks that physiotherapy is an effective treatment for cervicogenic headache? Anyone not? Hopefully not too many not. Okay. Who thinks physiotherapy can cure cervicogenic headache? Not as convinced? Come on, put your hands up and weigh in. Okay, what about migraine? Is physiotherapy an effective treatment for migraine? I thought you'd put your hand up, right? What do you think? Maybe? Effective, not effective? What do you mean, what sort of migraine?
Well, there's faster activities of migraine.
Yeah, we'll talk about that. Hold that thought, and we'll talk about it as we go on, because that's interesting, and that's one thing I think that physios have to be better at is that selecting of patients, and we'll talk about that in terms of the diagnostic categories and the musculoskeletal profile. So a few undecided, a few think probably not. What about tension type headache? So how many people here assess and treat headache in their routine clinical practice? There must be some sort of interest in it. So it's interesting, over a couple of honours students projects at La Trobe, we did surveys of physios as part of a large project, and we surveyed, there are over 170 patients who were seeing the physio primarily for their headaches. And you might think that most physios would mainly see cervicogenic headache. But of the 170, only 35% had diagnosable cervicogenic headache. About 28% could be diagnosed with migraine, of which about 28%, or 8% of the total would be migraine with aura, and about 28% with tension type headache, and there are about 10 or 11% that fitted into another category, not easily diagnosable. So there's more chance if you're in private practice as a physio of coming across a non-cervicogenic headache than a cervicogenic headache, and there's more likely it's going to be migraine or tension type headache, but combined. So I think it's really important for physios to be good at diagnosing those headache types and understanding what sort of musculoskeletal impairments you're likely to find in those headache types and what are the implications of those musculoskeletal impairments. So what I thought I'd do tonight is really go through it pretty much how you would go through in your clinical practice. We'll start with subjective examination, we'll go through what you might find with the physical examination, talk a little bit about proposed headache mechanisms, and then the implications of what you've found in terms of treatment. Happy with that? Cool. So what we'll start with is cervicogenic headache. Someone comes in and they've got a headache. What features of that headache would make you think it's cervicogenic headache? Can you take us?
Perhaps a postural link. So I don't get it on the weekends, but I do get it especially Thursday and Friday, end of the week in the office, prolonged sitting, that kind of thing.
Yeah, yep, absolutely. So that you're getting that with your aggravating factors. From headache behaviour, what about easing factors? What sort of things might indicate cervicogenic headache in the easing factors?
better in the morning?
Maybe, yeah. So rest can help. Anything else?
Lying down.
Lying down. So change of position.
Get my husband to give it a rub and it feels
Yeah.
better.
What about the people? What do you do to make it better? I get my fingers and I put my fingers and I rub my neck, or I push on the joints in my neck. That's really strong. So what about headache area? Is there anything typical in terms of the location? Someone comes in, you probably start with the body chart. What's in the body chart? What do you find?
Can be unilateral sort of pain.
Often unilateral, yeah, and that's Otto Jorstad, who's a Norwegian neurologist. That was his original definition. So unilateral or a unilateral bias, I would say that would make you think more strongly of cervicogenic, although migraines are often or more commonly unilateral as well. But there are other features that will help differentiate. So if it's bilateral, it's more likely to have a unilateral bias, but I still think there are cervicogenic headaches that have a bilateral distribution. I usually ask, where does the headache start? And so if they can pinpoint it, sometimes it's all over, but if it starts in the neck and radiates forward into their head, it's more strongly suggestive of cervicogenic. Migraine with aura is more likely, or migraine is more likely to start in the head and maybe then radiate over, and they will get neck pain associated with it. So unilateral headache, unilateral bias, if it starts in the neck, it's more strongly suggestive. I'm saying more strongly or less strongly because there's not anything that's absolute. And what you're trying to do is build up a clinical picture that would strongly indicate that that headache is likely to arise from the cervical spine. Nature or characteristic of the pain. So if it's coming from the cervical structure, probably more likely to be somatic referred pain unless there's like a neural connection with the greater occipital nerve. What's a characteristic of somatic referred pain?
Fairly constant.
Might be constant. If it's mechanical, you're probably more likely to fluctuate. What about the nature of the pain? Deep, vague, dull ache, more likely. Is it going to be severe or not severe or moderate to severe? You're doing well. This is making it really easy for me. Keep it up. Come on.
Certainly not as severe as migraine, as in I can function with this headache as opposed to I need to change my life and go home and turn
mild
the
to
lights out.
moderate, occasionally severe, but more in that moderate band, I would say. Okay. So that's the characteristics of it. There might be association with neck trauma, like whiplash or perhaps sporting trauma. So your past history might give you an idea. The link with associated neck pain might give you an idea, although we'll look at migraine tension type headache and they may have neck pain as well. So let's go on to migraine. So the criteria for migraine are it's a predominantly unilateral headache, but with the cervicogenic headache, as described by Jorster, it's more likely to be fixed unilateral. If it's unilateral in a migraine, it's more likely to swap sides in between or sometimes within an attack. Occasionally it'll be bilateral. The nature of migraine is more likely to be a throbbing, pulsatile headache, which is consistent with some sort of vascular nature or vascular component to the headache. Migraine is more likely to be severe. So migraine, a good way to think of it, it will tend to prohibit activity. So people with real migraines are the ones who have to go and lie down in a darkened room. So the person who rocks up to work and goes, I've got a migraine today, chirpy chipper, probably haven't got a migraine, not a true migraine anyway. But a lot of people call any sort of headache, particularly severe headaches, migraines, and that can make it difficult in terms of diagnosis and maybe some expectations of treatment. So, as I said, lying down in a darkened room, often they'll have photophobia or phonophobia. They're really sensitive to sound or light. They'll often have nausea or vomiting, and often aggravated by routine physical activity. So that even walking stairs or walking aggravates the headache, which is why they lie down in a darkened room. Tension type headache tends to be more mild to moderate, so it'll tend to inhibit rather than prohibit activities. People can usually function with tension type headache, and these are the International Headache Society criteria. It's more likely to be a dull ache, it's less likely to be pulsatile or throbbing. It's bilateral occipitofrontal, so people who have the pain all over their head, even everywhere. You say, where's your headache? And they go, it's in my head. Okay. But if it's all over the head, it's more likely pressing or tight or squeezing sensation. that's more likely to be associated with tension type headache. No nausea or vomiting. They may have one of photophobia or phonophobia with that, and not aggravated by routine physical activity. How are we going so far? So from the subjective examination, you're getting a bit of a picture about whether the headache's likely to have a cervical cause or likely to have a cervical component. I think personally, the more the headache resembles Jorstad's criteria, strict unilateral, aggravated by neck movements or sustained postures, eased by intervention to the neck, the more likely it is that it's cervicogenic. But you still need to do your physical examination to confirm the hypothesis you're making in your subjective examination. So what sort of musculoskeletal impairments might you find in cervicogenic headache? What do you reckon?
Restricted range.
Restricted range of motion, absolutely. Much more common in cervicogenic headache than tension type headache or migraine. You're looking at sort of population controls. When you've got cervical dysfunction, you're more likely to have decreased range of motion. Joint hypomobility or painful restriction of joint mobilising. So your manual examination, I think, is critical in the differential diagnosis of headaches. So painful joint, we'll call it dysfunction, because theoretically it could be hypermobile. Painful joint dysfunction is determined by manual examination, altered or decreased range of motion. You have to make a call whether that movement is going to be stiffly less for that patient. Usually if it's more unilateral, you're more likely to get a consistent unilateral restriction of movement. So I'm not saying if it's bilateral, it's not cervicogenic headache, but you're weighing it more on that cervicogenic pattern than if it's bilateral. What else? So we've got articular dysfunction maybe.
Muscle trigger points.
Muscle trigger points are an interesting one. So it depends on whether you believe in trigger points. What are trigger points? And I think trigger points, my thing is trigger points are a secondary manifestation in the muscles of probably central nervous system sensitivity. But yes, you get trigger points. We also get trigger points in migraine and tension type headache. Yeah, absolutely, in cervicogenic headache. Other muscle system dysfunction or impairment. What about, you remember those boring third-year pracs when you get the pressure biofeedback unit out and you get people nodding? Sorry, all throat grads and postgrads, I should say. So weakness or impairment in the deep neck flexors. And so this is, Gwen Giles, bit of Gwen Giles' baby, if I can say that, that she tends to push. But there are definite changes in deep neck flexor activation and strength. So weakness in the deep neck flexors on the craniocervical flexion test, which you tend not to get as commonly in migraine and tension type headache. So other muscle system impairments, you tend to get weakness in the flexors and the extensors. More likely to have weakness than you would for migraine and tension type headache. But then you have to decide for that person in front of you, that patient, is that weak compared to what they would normally be like? And you have to use your experience to make that call. It's easy when you're doing a study and you get a group of cervicogenic headache patients, group of migraine, group of tension type headache, if you want to go that far, and a group of controls. You say on average they're weaker in their flexors and extensors, but when you've got a patient in front of you and you haven't got that normative data, you have to make that call yourself based on your clinical judgment.
Ken, did you say the craniocervical flexion test for testing endurance? Can you briefly detail that? So
within the test, so when you do it, you feel your sternomastoid and anterior scalene activity as they do the nod, and usually arbitrary figure, if it's less than probably 5 or 6, I would say it's weak. But then I go and I test the endurance. I test the number of 10-second holds they can do. And often you find as you keep testing at different levels of activation, they get weaker and weaker. And I think when you get that decreased endurance, often that corresponds to the patients who their headache gets worse as the day progresses when they're sitting or their muscles fatigue, particularly those deep postural muscles like the deep neck flexors. So instead of looking at just the strength, I look at the ability to actually hold it for periods of time. And often it's fairly obvious early on when they've got that decreased endurance as well. Other people will do static holds, lifting the head, or looking at the extensors, doing extension work, or just holding across gravity for the extensors.
If we go Dr. Google and look this up, can we readily find vaguely normative data, or is it kind of
yeah, if you look up
experience
most
again,
of
or-
Gwen Giles' work, she'll give you a bit of an idea. Most people, my clinical experience, I think from Gwen's studies, ideal will be 8 to 10 millimetre increase with the pressure biofeedback. Ideal will be able to hold for 10 reps of 10 seconds. But realistically, if you're getting above 6 or 8 and you can hold probably 4 or 5 times, at that 10 seconds before you fatigue, I think that's reasonable. But you've got to take it in the context of what they do, what their occupation is, or their sporting requirements as well. Some people might not need that amount of endurance.
Yep.
So again, it's a bit of a clinical judgment. Okay, so we look at migraine and the tension type headache. That the research seems to indicate that you might have some patients with migraine and tension type headache might have positive upper cervical joint findings. Some might have weakness in the deep neck flexors, less likely to have deficits in the strength through their flexors and extensors. But one of Gwen Giles' studies that she did in conjunction with Niere, was that they showed there was this pattern of musculoskeletal impairments that was strongly predictive of cervicogenic headache, and that pattern was decreased range of motion on active movement testing, so impairment of craniocervical flexor function, strength and endurance, and painful upper cervical joint dysfunction. If you had those 3 elements, it was likely to be able to differentiate from your migraine and your tension type headache. So again, you're building up this pattern of impairments, and you're correlating that with your subjective examination, the hypothesis you've made from the subjective examination. You get all those things, all those ducks lined up, if you like. It, I think, is good prognostically and highly predictive of a good result from your treatment. So there's less reliable pattern in your migraine and your tension type headaches. One thing we're talking about the craniocervical flexors, I think one thing that hasn't been studied is often you do get that tightness through your upper cervical extensors or your cervical extensors. That hasn't really been reported in the literature, but you see patients who they've got the weakness in the deep neck flexors, they're sitting like this with their chin poked forward, and they get, it's almost Yanda stuff where you have that proximal cross syndrome, where you have the weakness in the neck flexors or the deep neck flexors and a corresponding tightness in the upper cervical or the superficial cervical extensors, and I think that's a really common pattern. So we've got a bit of an idea. If it's cervicogenic, it's more likely to have musculoskeletal dysfunction. If it's migraine or tension type headache, it's less likely, but there might still be significant findings. You might still be detecting musculoskeletal impairments in those headache types. Before we go on to treatment, I want to talk a little bit about the likely mechanisms of each headache, the pathophysiology of each of those headache types. So cervicogenic headache is what's known as a secondary headache. So a secondary headache is where there's pathology, demonstrable pathology, which is associated with the headache, which you can show to be associated with that headache. So with the secondary headache, the main, if we're talking about pain mechanisms, it's mainly a nociceptive input, so it's a peripheral driver to the headache. You can have some degree of central sensitization with a cervicogenic headache, but that tends to be either associated or secondary. But the main driver, if it's cervicogenic headache, in my opinion, is peripheral. That's a secondary headache. It could be a tumour. A tumour is a secondary headache. Subarachnoid hemorrhage is a secondary headache where you have a shown peripheral driver giving you that pain. Migraine and tension type headaches are what's known as primary headaches, where the driver, the pathophysiology, instead of in the periphery, is in the central nervous system. So we'll come back to that. So cervicogenic headache, secondary headache, painful musculoskeletal dysfunction or impairment is giving you the headache. Right. With migraine, the likely mechanism, the proposed mechanism, this is something that's evolved over probably decades, whereas initially it was thought that migraine was caused by a vasodilatation of the cranial blood vessels, giving you the characteristic throbbing headache. And migraine with aura, where you have the reversible neurological deficit, is caused by vasoconstriction of intracranial vessels. That's not quite accurate now. It's thought that migraine is caused by a profound disinhibition of the central nervous system, so what we call the trigeminocervical nucleus. There's a strong genetic component to migraine. With most, when I ask people, do you have a family history of headaches or do you have a family history of migraine? Often you'll be able to find it either immediately or at least a couple of generations back. So patients with migraine have this genetic predisposition to almost like instability within the trigeminocervical nucleus. And there tend to be triggers, characteristic triggers. Some are readily identifiable, other times it's not so readily identifiable, but certain things will trigger the onset of the headache or that disinhibition. So they get a severe onset of pain, and as a secondary reaction they get a sterile inflammation of the dural blood vessels, which gives the characteristic throbbing nature of the headache. And the reason why it often responds to aspirin or non-steroidal anti-inflammatories. So the throbbing and the vascular thing is a secondary effect to the actual disinhibition or sudden sensitization of the trigeminocervical nucleus.
With Dean Watson's work maybe a long time ago now, but looking at, O3, 1, 2, 3, all putting onto trigeminal nucleus, where do you think all of that fits in, if at all, or it's all
so the upper,
rubbish?
we'll talk about that, because the upper three cervical segments have strong inputs into that trigeminocervical nucleus, and like with anything, you can modulate the sensitivity in musculoskeletal physios. We know we can modulate central sensitization with appropriate input. And I think manual therapy is a fantastic way to do that in a positive, supportive, therapeutic environment. So you get good peripheral input and you encourage them, you get good descending inhibition. It's a really powerful way, I think, to decrease. And I think a lot of what we do is decreasing central sensitivity. And there's certainly, I think, that central sensitivity in cervicogenic headache. But the role it plays in migraine tension type headache may be different.
Yeah.
So if we look at tension type headache, again, tension type headache has a strong genetic component. The tension type headache, there seems to be a more constant or a lower level disinhibition or sensitivity within the central nervous system, within that trigeminocervical nucleus. So where migraine, it fluctuates up and down depending on the triggers. Tension type headache tends to be a sort of a lower level of disinhibition. So it's sensitive, but not in a massive way that migraine is. So the headache's not as severe. You don't get those other phenomena of photophobia and phonophobia, or even the vomiting associated with that. So tension type headache will often respond to drugs, amitriptyline and tricyclic antidepressant, which increases or decreases the sensitivity of the trigeminocervical nucleus. There was a study, a physio study, that was fairly strong, what they call craniocervical flexor training, so they said low load, but I would have said high load, looking at flexors and also training extensors, which seemed to be effective in treating tension type headache. And it would appear that with migraine and the tension type headache, the more chronic they are, the more likely they are to have associated cervical musculoskeletal dysfunction. So it can happen. So if it's migraine, you just don't say, oh, you've got a migraine, I don't think I can help you. You would certainly examine them, see how much musculoskeletal dysfunction they've got, and work out the role of that musculoskeletal dysfunction with an understanding of the underlying pathophysiology. So I think it's important to be able to diagnose these headaches because it helps with your prediction of that, of prognosis.
Okay. I assume they're not mutually exclusive.
Now, people can have what they call mixed headache types, and often patients will say, I get migraines, but I also get headaches that I think are coming from the neck. And if we talk about triggers for migraine, we talk about menstrual triggers, certain foods, sleep disturbances, stress or relief of stress in migraines. I always ask about the triggers in the subjective examination. I think neck pain can sometimes be a trigger as well in some people. Like I think painful musculoskeletal dysfunction can be a trigger, and often if it's associated with other things. For some people, it's not it's not typical. It might be a build-up of various factors. Some people, it's really obvious. Chocolate gives me migraines. I don't eat chocolate. I'm less likely to get a migraine. It could be red wine. It could be certain foods. Don't smoke certain perfumes. But some people, it's not that obvious. So we've got provisional diagnosis of these patients' headaches. We've done an accurate, targeted examination. We've got an idea of the articular dysfunction from our active movement testing and our manual examination, maybe looking at Toby Hall's flexion rotation test. We've had an idea of the muscle strength we're compared to what our idea of normal might be. So we've got a pattern, we've got an idea of the associated impairments to these headache types. So what do? Physios, you treat them. Absolutely treat them. But I think in the context of maybe other management, I think with cervicogenic headache, where you've got that pattern of musculoskeletal impairment, I think that's highly predictive, and there's level 1 evidence to show that physiotherapy, a combination of manual therapy and exercise therapy, is effective for treating cervicogenic headache as per Jules Starr's criteria, and I back that up with my clinical impressions. The evidence is less strong for migraine. In fact, I don't think there's convincing evidence for migraine. Tension type headache tends to be a little bit mixed, a bit muddled. I think in tension type headache, sometimes you can get secondary musculoskeletal impairments that are contributing to the headache. And I think you can get that in migraine as well. So are you treating the cause of the headache? You're treating the problem. So if you're treating the cause, you should be able to cure them. We'll go pretty close. Or are you treating as the musculoskeletal impairment an associated thing that's contributing to the headache, which I think happens a lot in migraine and tension type headache? Or is the musculoskeletal impairment just there anyway and probably has no bearing on the headache? So I think that's where our treatment will be able to tell. If you've got strong musculoskeletal impairments, it's consistent with the headache, treat them and see what happens. But remember that it's a therapeutic environment, the patient wants you to get them better, you want to get them better. There's a fair placebo response to this, and I think with a lot of them, they seem to have really good results, and it might decrease the frequency of their tension type headache or their migraine, but over a period of time, those headaches gradually start coming back again. So I think physios can be a really useful adjunct to the treatment of migraine and tension type headache. But in terms of the underlying pathophysiology, I'm not convinced, and coming back to your question, we can change that. I think we can alter it temporarily, and that temporarily might be over a period of time. So regular treatment might be really useful. But I think it's got to be in conjunction with other, if you like, proven therapies, your triptans, maybe your beta blockers or your membrane stabilisers for migraine as preventions. And often the patients will be the judge. They're often discerning consumers. They know what effect the physio treatment has. With tension type headache, a bit harder. You can have a good result. I think the more musculoskeletal dysfunction you've got in the tension type headache, the more likely you are to help them, maybe not cure them, because you have to consider what's causing that central what's contributing to that central sensitivity. It's a strongly genetic thing. I don't think you can change, as powerful as our treatment might be, I don't think you can change the genetic makeup of your patient. But I think you can change, or you can alter, at least temporarily, and maybe in a longer term phase, that central sensitivity, like a lot of things, like stress management, biofeedback, certain drugs can help with that. So it can be a useful adjunct. So if I had to sort of overview, and I've been skirting around a little bit, I think, and look, some cervicogenic headaches don't respond well to just a physio. They might need joint blocks, they might need other things to help with their central sensitivity. But as a general overview, I think we can coming back to my initial question, we can be more confident that we can cure cervicogenic headache. I think the prognosis will be better if you've got your typical pattern, your pattern of impairments, they are more likely to respond to your treatment. With your migraine and tension type headache, I think you're less likely to be able to cure them, realistically, but the stronger the musculoskeletal impairments are, the more likely you are to be able to help them and help them manage in conjunction with other things. the less strong those musculoskeletal impairments are, or if there are no musculoskeletal impairments, and some patients I see come in and there's really not much going on in their upper cervical spine. I say, look, I don't think I can help you. I don't think there's a significant cervical component. So the less strong those cervical impairments are, the less likely you are to be able to help them, the more likely they really need other assistance. But as I said, if you've got the impairments, treat them in the context of overall management. Be realistic and honest as to whether your treatment is helping them. So we've got any questions based on that?
With hormonal headaches, do you give them any sort of advice whether they should see their GP and think about changing contraception?
Yeah, magnesium supplements really good, and there's some evidence to suggest that magnesium supplements can be useful for menstrual migraine, but when it's really strongly associated, seeing their GP or an endocrinologist, gynecologist can be really helpful for that. So it's more likely and there's a separate diagnostic category of menstrual migraine, which tends to be pre-menstrual, but sometimes you can get increased headache activity at ovulation where there's a spike and then a fall in your estrogen and progesterone levels. But my initial thing is try migraine supplements because sometimes they work brilliantly. The questions, Mark?
How do you manage or your mindset when you're approaching a patient around sensitivity so you don't, even with your manual examination, flare them to the point where they're fainting and not able to leave the room for half an hour?
I think the more, and this is where you get the behaviour of the headaches easily provoked and often by previous therapists as real alarm bells. You know? I saw Ken Niere and he put me in hospital, because he was too rough. That's anecdotal, of course. So you're asking about the past response to treatment. If it's easily flared up and if it's quite severe, really back off. I don't push them too hard. It's like with anything like a back or a neck or a whiplash. If it's sounding like it's quite sensitive, it's the old Maitland concept of irritability. That if they're irritable, go gently to begin with. Yeah, go really gently.
So you may not do a full musculoskeletal examination?
I won't push them too hard, and I'll be asking them all the way through what's happening to your headache. Find out their headache status when they come in and keep asking them if they're likely to be irritable. If it's likely you're stirring them up, then back off and do some techniques that are going to make them happy. And it might be pharmacological, it might be gentle traction, it might be massage, it could be hot packs, whatever. The more irritable, back off. Don't push them too hard. But if they're not irritable, go for it. And I think if you can provoke their headache or reproduce their headache, it's more predictive of a positive response, or more predictive that the cervical spine plays a role in it. Like if someone's really sensitised centrally, it's easy to provoke them and easy to reproduce their headache. That doesn't mean the headache's coming from their neck. It means that you're having an input via the part, which might be useful therapeutically, but you have to base that on the likely degree of central sensitivity.
So if you have that patient that comes in that has the reduced cervical flexion rotation, ipsilaterally matches with the headache, push on their neck,
Reproduces.
gapping OC1, reproduces, hold it lessens their headache, but 3 months later they're still coming, and you lessen their headache and they get relief for a few days or a week or 2 weeks or whatever. Is it that you're not good enough to get them better? Is it that you need to send them on? And if so, who would you refer to?
If that's happening, so if joint blocks can be useful, if you think it's strong enough, or is there a contributing factor you're not getting, you're not understanding? That can be like anything. It can be psychosocial.
Yeah.
It can be postural. Maybe the stomach, they're sleeping on their stomach with their head jammed like that, and they can't get out of that. It could be stress, even with strongly cervicogenic. They're under stress. Nothing like stress to arc up your musculoskeletal symptoms. So, or is it just that they're in that pattern, they get in this cycle of pain and central sensitivity and more pain that they can't get out of? And I think joint blocks can be really useful to break that cycle. But I always say this is something that's going to break the cycle, but you still have to address these other impairments and those other contributing factors, postural or psychosocial or whatever it is.
And from a medical point of view, do you have a go-to, apart from sending them to GP, because that's a kind of mixed bag, but Did you have somebody that you would say, oh, these people are great, that I would, refer
For the
via them?
joint blocks?
Yeah, or just
Yeah.
for that tricky patient that you think they're not, they need more help than me, where do I send them to next?
Yeah,
Because often they go to the GP and get a worse
Yeah,
answer.
no, it helps if you work with a neurologist who understands the role of the cervical spine.
Yep.
Or sometimes it can be awkward because the neurologists
Don't get it either.
don't get it, and ethically you're going, well, do I go to my neurologist back? Or I suppose you have to be, the patient has to be number one, but you have to be a little bit careful with that. So neurologists, you might say, you might like a second opinion here. This person is really good. Or with the joint blocks, if you've got a group that does joint blocks really well, I think the radiologists are pretty good with this. And if you can help train them up, but it's helpful if they've got some sort of physio input, and they really value the input of physios, definitely in terms of manual examination. So I use Imaging Associates in Box Hill, great for the joint blocks. Yeah.
And in terms of a name, we want names.
Oh yeah, it's hard.
Of, somebody that you would say, send this bloke away, horrible.
Yeah, I like Brian Chambers as a neurologist. I think he's really good. Yeah, he was in Greensboro. I think he's practicing in Heidelberg now. But there are various neurology groups around, and some of them are good and some are not so good.
Yeah, I've just got a very engaged, awesome mum that wants the answer and can't find it, and it's been through the ringer, and I'm like, well, I don't know that much, but I'll at least tell you if it's from his neck or not to a degree, and we got through that, and it seemed to get better, but not fixed, and
yes.
And she's like, I'm just so sick of, he's seen neurologists, he's seen rheumatologists, he's seen dietary people, he's seen, and you're like, where do I start?
There are some people who, despite your best efforts and your best treatment, it's persistent.
Yeah.
And then I think it's that central sensitivity for whatever reason. You see people with what they call the new persistent daily headaches that, they have a virus or they wake up and they've got this headache and they just can't shake it. They're really hard to help. Sometimes it gradually dies away, sometimes your treatment can help, sometimes pharmacology can help, but sometimes they just become persistent. It's hard. So if you're not helping them, you don't keep treating them. But as I said, the person will decide on whether you're the right person. So you'll give them, and even a few days or a week symptomatic relief can be really powerful. Even though you're not helping them the overall, but you're giving them some hope while they find answers from elsewhere, and you can help facilitate that, I think. Anything else? How are we going for time, Mark?
Good. A couple more questions.
Is it so it's the neurologist who will refer for the joint blocks in the end?
No, the GP can refer for a joint block, so if you've got a good relationship with your GP. And I always like to make sure that over maybe 2 or 3 visits that their joint findings are quite consistent before I write it down. And sometimes they'll just inject the joint that shows up worse on imaging, unfortunately, which might not be the most provocative or the most painful one. But it's got to be consistent response to your accurate manual examination. And that's better than they'll usually do in the radiology clinic, or better than the GP will do. Some clinics will just block everything, of course, which I don't think is particularly helpful. Not in the long run, particularly if you're getting some denervation of the multifidus, which is a pretty handy muscle for cervical muscle control.
What are they injecting?
They usually inject the medial branch, the nerve that supplies the joint. So if they get a positive response to the block and the pain comes back, they'll often do radio frequency denervation where they cauterize or coagulate that sensory nerve.
And that will last for like a year or 2 or whatever, and then they need to do it again.
Yeah, it's interesting. Some people get like months or a year's response even from a joint block, from local anaesthetic and steroid mix that will probably wear off in hours or weeks. But I think it just breaks that pain cycle and gives them, almost like resets their nervous system, gives them a chance to have normal input and desensitise it. And maybe sometimes our manual therapy can have that same effect.
What's your experience with migraine and vestibular symptoms?
Yeah, it's interesting.
Treat them separately
Yeah, vestibular migraine seems to be a common diagnosis, and really it's not it's not a migraine, but they're saying it's a similar thing. It's like a periodic or episodic sensitization of, instead of the headache system, where you get a migraine, the vestibular system where they get this dizziness. And they treat it similar to how they would treat a migraine with drugs to decrease that sensitivity, or even out the peaks and troughs within the sensitivity of the trigeminal cervical nucleus. But certainly with upper cervical dysfunction, cervicogenic dizziness is a common association or a common manifestation as well. But vestibular migraine is not a migraine, it's an episodic vestibular problem. Can I say that NeckRests are really effective at treating all musculoskeletal impairments associated with headache? I must have forgotten that. I'll discharge my duties now.
Thanks, Ken.
Done. You're welcome.
So I thought it appropriate to get Ken to come and speak on headaches and neck pain based on his expertise. I think one other answer to your question that Ken would be too humble to talk to is using APA specialist musculoskeletal physiotherapist as a specialist. And Ken, having referred, I would say, 10s, 20s, 30s, maybe close to 100 of friends, family, patients, etc. to Ken, he's not the kind of physio that will keep them. He'll treat, he'll assess, treat, give you advice on the phone, letter back, and you keep managing that patient. So my answer to that question would be send it to Ken and back to you, and then. So look, I'm a physiotherapist as well, a sports physio. So we've got to look after our backs and necks. Everyone stand up for a second and face this way. Hands free, drinks down. Hands on the person in front of you, give them a little massage. Right, turn around and repay the favour. Alright, take a seat, thank you. Get the endorphins flowing. So can I just ask a couple of questions around your source or channel of getting here? Who is a La Trobe email through, either being a current student or an alumni through La Trobe University? Fantastic. These may not be mutually exclusive, so I understand that. Who got an email from Whiteley? Yeah. Who got an email from Sports Tech? A couple there. Okay. Who came through Ken's network? There's a few there. Excellent. Who have I missed? Have I missed my personal network emails? There we go. A couple of personal physio friends. Great. I just wanted to know from knowing where you all came from. So. Thanks for coming to the launch of NeckRest. I'm going to talk through a few things. Background of both myself and the products. Talk through the science behind the product, demonstration, and then talk through finishing where you can purchase the product. So a bit of background. Like I said at the start, I'm a sports physiotherapist. I actually had a fair bit of back pain. You would think, well, physios shouldn't have back pain. Most of us do, but I laboured my way through university prior to becoming a physio and stuffed up my back, lifting too many heavy things. And it was around the early stage of my physio career, I suffered a lot of back problems lifting patients at Royal Brisbane Hospital, and in those days there were no hoists. So I was lying on a thoracic wedge, and it actually made me worse, and I thought, this is unsafe, and some patients were getting worse with it, so I thought, there's nothing that, and I was seeing not Ken, because I was in Queensland. When I'm down here I see Ken, but I was getting treated, and I thought, why can't I go home? And I'm lying on a rolled up towel with tape around it like they recommended in the mid-90s and late 90s, and this is doing nothing. So I started lying on a golf ball, a tennis ball, a cross ball, and all these sorts of things to try and get relief. And that's when it started to think, there's got to be something I can do. And that was the genesis of back balls. And the other angle of back balls was that I was looking after the Australian Olympic triathlon team, and they were going overseas, and foam rollers weren't around in those days, and they were coming back after 2 to 3 months travelling, and they were back to where they were, if not worse, than where they were prior to departure after me treating them. So I wanted something, and it was really physio in a pocket. I wanted for them to travel around the world with me in their pocket, and that's where back balls came from. And it took a number of years of trialling the size, the density, and I used Punjabi's research. He's a fantastic researcher many decades ago that has mapped the anatomy of the spine structurally around cervicothoracic and lumbar and the specific sizes. And yes, there's ranges and standard deviations of this, but whether you're 5 foot or 6 foot, the size of your spine doesn't vary that much by a millimetre or two. So I use the dimensions of the spine so that the back balls, when you're lying on that, you're hitting the costotransverse in the thoracic and the facet, and then the transverse process of inner rotation on the lumbar spine to bring science to it, so that when I was lying on the back balls, it was just like Ken Niere's thumbs going into my back. And the same science is there on the NeckRest, and I'll talk to that in a second. I apologise for these notes. Sick children at the moment. I've been in hospital the last couple of nights and I haven't got much sleep, so I didn't trust myself to remember everything, so my apologies for that. Before I go into the NeckRest, I just want to talk about the causes. And I think Ken's spoken about headache and obviously neck pain, but in my experience, and to me, the Bachelor of Physiotherapy, if you throw that into 4 letters, TWYF, and I think the La Trobe students, if you remember from my lectures, here's an examination of memory from your master's course, but to me, the 4 letters of physiotherapy are TWYF, and maybe that's my Queensland background as well. Do you know what that stands for? Treat what you find. So I'm not physiotherapist that says, back balls and NeckRest for everyone, because clearly that's not appropriate, but for the appropriate patients, you've assessed and you've treated what you've found. The appropriate patient, stiff mid-thoracic, throw them on a foam roller or a back ball. The appropriate patients where you've assessed their cervical spine, you are going to refer, obviously prescribe tennis balls, lacrosse balls, NeckRest, whatever you think is appropriate for that patient. So I am a registered physiotherapist. I'm a professional that is about doing no harm and doing what's best for the patient, long-term management so that they are self-managing and you're aiming for a cure. I'm not a businessman that is here to sell product, but yes, clearly there's an association there, but I just want to make that clear right from the start. So to me, treating what you find, the manual side of physiotherapy is great, but if you're not dealing with the primary causes, and that's not cervical dysfunction, that is postural, that's whatever's coming that beforehand that leads to that dysfunction, we've got to start back here. So I think that's really important. And to me, and again, I'm no expert in cervical treatment compared to Ken, but you're looking at I guess from a sports physio background and coming from Queensland where there's a high bias towards physics in our course and the mechanical side of load and load management from Gwen Joel, Paul Hodges, Bill Vincenzino, Carolyn Richardson, etc. It's about the load going through the spine. And I always considered myself a mechanical engineer of the body as a sports physio. And to me, if you just think about basic thoracic kyphosis, the sitting at a computer all day, the smoking of the 21st century is sedentary lifestyle and sitting, and then you are jamming the joints in your upper cervical, but cervical spine, just everyone get your fingers up like that and just jam the little finger like so. This is what I do with patients. And just do that for 5 seconds into hyperextension and it starts to hurt. So that's my explanation. I think anecdotes and practical techniques like that are very important for patients to understand they're going home and why their pain is there. To me, it's compression of those cervico and upper thoracic, but really cervico facet joints. But then if you think about the muscular system, and the upper cervical extensors are clearly in that shortened position, and Ken spoke to that. But then if you think, well, where does the pain come from? And yet trigger points, there's theories behind that, no fact. But there are studies that show, and in rats, and yes, in animal studies, you stick them in plaster casts, and within 6 weeks you are getting a physical shortening in the number of sarcomeres. So you are physically shortening the muscle. And if you are like that, and I'm sure you've all treated patients decades, 20, 30 years of sitting, my hypothesis is their muscles are actually shorter, so therefore there's going to be potentially inherent tightness in that muscle. Then when they're getting up into normal postures, their upper cervical extensors are then extending. So obviously the need to stretch out, like why does that get them relief? Why do they feel that urge to do that and extending? But then if they're stuck in reading or they're looking down an extended period of time in that upper cervical area, that tension can then lead to that headache. So I like to go back to the mechanics of that. Clearly tension, migraine, if it's not mechanical, not cervical related, then clearly irrelevant, unless there is that component as Ken spoke to. But that's where I start with neck pain. And that's where I came to NeckRest. Like back to 2002 when I patented back balls, took 2 years of research and development on the size and the density to get it to try and replicate my thumbs or an expert physio thumbs into someone's back. In the business plan, I went and did an MBA subject because I knew nothing about business, and through that subject I ended up developing a business plan, which led to winning a business plan competition, which was fantastic to give me a little bit of money to help develop the product, got me on a current affair, which is fantastic for the product to then develop other inventions. But when it comes to the NeckRest, within that original business plan was, yes, back balls for the back, but NeckRest for the neck. And it's taken a long time, a lot of years to get to this point. And if you look at where it actually comes from, and if you think about the pivot position, so you've got your patient in supine, you're sitting or standing, but you've got your fingers in that position. Who uses that treatment technique from an assessment and a treatment? I'll go the other way. Who doesn't do that? So, okay, that's fine. But majority, I'm talking to the converted here, our fingers are going up in there. And from a science perspective, I'm sure you were doing the same, but I'm first of all feeling soft tissue for tension, tone, tightness, etc. And feeling through the cervical spine. Then from a pivot perspective, in vertebral movement, you're feeling rotation, lateral flexion, etc. in that position. And then you treat what you find. So from a treatment technique, and especially having been treated by Ken, my family's all been treated, his hands have been all over my I shouldn't say wife, but majority, hopefully just their spines, but families, etc., have gone in to see Ken, and that treatment is the force going up into the neck, and that's where I got to with the product. I wanted that force going up into the neck with the gravity of the head, gravitational forces, I should say, of the head and the body onto the NeckRest, and it's replicating that position. So our fingers going into the upper cervical spine and the lower cervical spine. And the distances here are the facet joints of upper, lower, and then the mastoid process. So when you are getting the patient in supine and you're around at that upper cervical attachments onto the occiput, that's clearly where your fingers are actually going in and palpating for soft tissue issues in that area, and that's the science behind the NeckRest. Now, Punjabi was also the source of that, and I'd recommend having a look, just for no other reason that he's a fantastic researcher and has some great papers there many years ago, so it's not that recent, but clearly when you look at cadaveric studies of the anatomy of our spine and of our body, they're not going to change too much over the years. So, demonstration on the product. Who's got a little bit of upper cervical or neck issues? Anyone in the front row? It's kind of handy. Front row. Yeah, jump on that. That's fine. I might get you head up that end if that's okay. So, lie on your back for me. There's absolutely no assessment here. So, are you going to go through irritability though? Are you going to end up fainting on me or passing out or anything like that?
No, I have two issues. I just woke up.
Say that again, sir.
I don't normally have two issues. I just woke up with it this morning.
There we go. No pressure here. When I was a junior physio, I did put a patient, I wouldn't say in hospital like Ken did, but I definitely laid them down for a couple of hours and they weren't getting up. And I think, pushing the boundaries, I would recommend that, but probably not that far. So then I came back conservative and worked my way back up, and that was very early on in my physio career, 20-something years ago. So I think we're on the head here. Yeah, let's slide down a little bit that way, if we can. That's it. So, for upper cervical, I've got a position A and a position B on the side of the neck rest. It's very simple, and the packaging that comes with the product, you can see position A, feet that way, head that way. So you're sliding that into the upper cervical area. So can you lift up? And you can control that so you're getting that, use your hands if you can, and get that right in the upper cervical, so CO1 area, the base of the skull. Now on a physio bed, we've got texture on the bottom of the bottom of the neck rest. It's much easier to use on the floor for the patient. That's how I designed it, for carpet and wooden floorboards, so that the patient, so it doesn't slide. On a soft physio bed, it can slide, but it's soft, so you're not going to get the force there. But it's an easy way to demonstrate with your patients, but you may just have to hold it in position there. And again, you treat what you find. So if it's not appropriate for your patient, you don't think there's that upper cervical, you're clearly not going to do this. So it's the patients that you feel it's appropriate, and you've just treated them, and you want to send them home, just like thoracic stiffness, foam roller, back balls, neck pain, tightness in the upper cervical extensors. You want some trigger point relief or some muscular massaging force going into that. I'm going to talk about some philosophy of physio a little bit later, but because I think we go from a causation and correlation between what we do and we hypothesize where we get the pathophysiological benefit of treatment, but I think that's our hypothesis, and there's no real fact behind it. A bit like McConnell's taping of the knee. 20 years ago, we thought we were moving the patella. But a lot of research shows you're not really changing the position of the patella. There's a lot of other pathophysiological reasons behind why the pain reduces. So here, I'm not going to suggest I know exactly why, and even with physio treatment, why we're mobilising joints or even we're not releasing muscle, we're massaging muscle or putting direct pressure onto a muscle while we get relief. But, from this treatment, we are thinking about the facts, gravity, weight of the head, onto neck rest, pressure into the muscle. Is it going into the joint indirectly through muscle that is that thick? So we may be getting some articular effect, but I would say minimal from a direct treatment at rest. But then, as my lovely patient Irene here is doing, she's finding the sore bits. So as a patient, they're not going to be as informed as a physio. So you are going to have to demonstrate and get them onto where your thumb was obviously treating. But I generally look at every second day, because if you go every day, they can get flared up like any patient, like any treatment in the upper cervical area. 2 to 3 minutes centrally, and then you can actually get them to rotate, as Irene has been doing, and finding that sore trigger point, whatever it is, and I'm not going to say I know exactly what that is. Ken, do you think trigger points exist?
Yeah, absolutely.
And what's the internal physiology of a trigger point?
I think there's increased tone or increased tension within that muscle.
Yeah. And that's what I think as well. I just want to ask Ken, the expert. And how I demonstrate to patients, I say, look, your trigger point's like this, and then we're sticking our thumb either from that or neck rest in that position, and over time, 20, 30 seconds, that tonicity reduces. That's my explanation to a patient. Dry needling, I love dry needling. I was never skillful enough to stick needles in the upper cervical area. Good luck to those highly trained physios in the audience that do that. I think it's fantastic. Use a lot of other areas in the body. But this is the basic treatment using a neck rest. 4 to 5 minutes every second day. Initially, you can build up to every day and it's slid down a little bit though, hasn't it? Yeah. So the patient can hold that, or you can hold that on the bed, but on the floor it doesn't slide, or you can put it on a non-slip yoga mat, etc. So that's upper cervical treatment. So any questions about it? It's quite self-explanatory, isn't it? How does that feel? Slip you $5 later? Okay, so that's upper cervical. So let's slide that out now. For headaches, again, treating what you find, if it's unilateral and you're treating more upper right, CO1, 1, 2, then central, you're getting that release bilaterally. I shouldn't say release, the term is surgical, using a scalpel, so we're not releasing anything. We're reducing the hypertonicity in that area. But then right, if it's right side, obviously you're getting them right rotation, and you're trying to replicate. And can I just say, I'm not trying to put us out of business. I mean, they're always going to come back to you. You're a good physio, you're a good health professional, they're going to come back. But what we do as physios compared to other professions, we give people strategies that they can go home and look after themselves. So why not try and replicate the exact sensation from your thumb with a device that they can go home and use? That's my theory. And when I'm using back balls, etc., treat a patient, lie them on the floor. Does that feel the same as my thumb? Great, do that at home every day. Happy days. So for lower cervical, cervicothoracic junction area, it's position B. So position B, you spin it around and head that way, feet that way. It's just the reverse. And again, you think of laws of physics. Here, we've got an angulation that way. So the laws of physics, that's 90 degrees between the angle of the spine and the NeckRest force. But the angle is that way in lower cervical, cervicothoracic junction, so you spin it around and you get the force that way. And you can see why we're going to bridge in a minute and we're going to get even more force into that cervicothoracic junction. So I'm not sure whether you have any lower cervical or cervicothoracic stiffness or issues, but let's have a go. I use the pillow with this because if you are, but just more at the, not full pillow, it's just really at the base of the skull. Because if you are using that in lower cervical, you can drop back in too much hyperextension, and that's clearly inappropriate for the patient. So I tend to get this in the upper thoracic region first, so just lift up for me, and in that position. Now we've got a very soft bed. I'm not sure if that's central. Does that feel central? Yep. Okay. Upper thoracic area there, and arms wrapped around, so we're bringing the scap out of the way and putting rhomboids, etc., on extension or elongated. Because of the soft bed, you may not feel much there, but bridge up and try and get the force down into the position. So you can feel that force as if we've got some thumbs going up into that region, and that's it. Okay, so in the lower cervical and then upper thoracic, it really is, after treating what you found, you're demonstrating the patient where they should be targeting, and you send them home with the product to target that specific area. Again, like back balls, like NeckRest, it's not the cure-all for everything. It is really, you're treating what you found, but in this lower but to mid cervical, that C4-5 area, I have found that the best way of getting that, and it's on the floor, remove the pillow, we're getting in that mid cervical area on the floor. You do have to flatten your lordosis onto the actual product, and I'm going to be perfectly honest, it doesn't go close to what our thumbs can do in that area. Based on, again, the laws of physics, yes, but in that area, it's very difficult to get the appropriate force or the similar force that we're putting in that area, but it still can provide relief. But I do it in that position on the floor, and you can just get that more relaxation, but you aren't going to get a deep treatment like you are upper and lower.
So with the mid-cervical, would you still improve it by using the pillow a bit or not?
Can you say what by using a pillow?
You're saying the mid-cervical is harder to target.
Yep.
Yeah. Would you still help that by using a pillow
I
a bit?
remove the pillow so that I can get the lordosis drop down onto the product as much as possible. So lower cervical, but really cervicothoracic junction, I want to support the head. And then you're getting a bridging to get the force through that area. You don't need a pillow for the upper cervical, but in the mid cervical, that's where you remove the pillow and drop that down. So clearly, contraindications for this, you're hyper-irritable, hypersensitive patient. So clearly, based on what you've found with your hands and the reaction to your both physical assessment but then treatment, you're not going to send the patient home with flared headaches and they're severely irritable. I would be extremely wary of nerve root and irritability from pins and needles, numbness, so contraindications in that area. But generally, the patients that respond to your hands are going to respond to this. Okay, thank you. Take a seat. You'll get a complimentary one on the way in, so hopefully that helps you out. So I'm just going to check my notes to see if I have missed anything and then finish up. So from a instructional perspective, we're actually going to put this video, I'll answer your question in a second, we're going to put this video, both of Ken's presentation and my presentation, on the BakBalls and NeckRest website, so feel free to send your colleagues and patients to that, and we have a number of videos on how to use the NeckRest, like I've gone through today, but in more detail, so you can send your patients there. You've got brochures on your seat, but also in your gift pack that you'll get on the way out. Sorry, answer your question?
Just interested, with them relieving the lower neck pain and you're getting them to bridge, are you expecting them to stay in that bridge position for 3 to 4 minutes?
No, 20 to 30 seconds. So a bit like a mobilisation or direct pressure at the trigger point, up 20 to 30 seconds, but I would expect their pain levels to reduce, so you educate your patient like that. If it's staying the same, it could just be block stiffness of the upper thoracic, cervicothoracic junction area, which I actually wouldn't then mind, as long as you've tested them and they're not becoming irritable, you can actually leave them there for longer. So for me, there's a region, NeckRest down to this area, and then the BakBalls take over there down. I haven't actually used the NeckRest for the thoracic treatment because I designed the BakBalls specifically for that anatomically, but then once you're getting down to that upper thoracic T2-3, that's where I just swap to the BakBall and use that area. And I do bridge up for upwards of a minute or two. Just again, laws of physics. You're lying on the BakBall in T5-6, foam roller, towel, whatever you're using, clearly the laws of physics, you're going to get max force F. Here though, you need to bridge to get that gravitational force in that area. So yeah, start 20 to 30. If it's muscular, you can go longer if it's structural. If you're thinking that it is just purely structural, so you are trying to reverse that structural kyphosis.